Hey, everybody, welcome to the Home Care Forum podcast with your host, Sasha, Guillaume, and Emina Poricanin. Special guest here today. Emina, if you don't mind, I'll introduce Desmond Martinez. Many people in the industry know Desmond from conferences, well, you know what? We're going to let you speak to that, right? Because you've been in the industry in a few different forms. But Emina, I'll pass to you. You can then pass to Desmond to start speaking about himself.
Thanks, Sasha. I echo Sasha's sentiments and the warm welcome. We are so pleased to have you today. We're going to learn a lot. It's not going to be just a Desmond-focused love fest here. You do have a lot of substantive information to share with us and our listeners, so thank you for taking the time. And why don't we start by having you introduce yourself to our listeners and tell us you've had I don't know, maybe 2 decades at least of experience in home care in New York State. So tell us a little bit about how I got started and how you ended up being where you are.
Sure. Well, thank you, Emina, and thank you, Sasha. It's a pleasure being on this podcast. I'm an avid fan, and yeah, it's 2 decades. Wow. So yeah, I'm still only 25 years old, but um, it's been a great journey. It continues to be a great journey. My background, even prior to home care, was in the EMR space, working in hospitals, physician groups. And then I transitioned and I ended up working for a company called HHA Exchange. A lot of folks may know the name, and worked there for many years from inception with the CEO Rafael Nadal. And it's been a great journey, and then pretty much in the whole journey of it all, it's been quite interesting meeting great individuals like yourselves and the whole cast and assemblage of different individuals who make up home care, right? From you have the caregivers to the owners to the coordinators to the home health aides to the patients themselves and the family, and it's a unique dynamic that you cannot replicate anywhere else. And so, making that transition from EMR, hospital physicians, to the home care world, I'm glad I did. And the reason being, I think there's a lot more advocacy, there's more sympathy, empathy, and I think just a good a group of folks that really, really care and really want to make a difference in this home care space. And so, in this whole 2 decades or so, I focus primarily in working on not only bringing different solutions to the space, mostly home care, IT, practice management software solutions, but also looking to implement those workflows and make sense. So yeah, so it's been a great journey, continues to be so. And yeah, I guess that's who I am and what I continue to be doing.
Tell us a little bit about what you do in your current gig. I see for those of you who are listening to this and do not have the YouTube recording, Desmond is prominently displaying the remote focus logo on his video camera. So tell us a little bit about what remote focus is and then what it does and what you do there.
Oh, sure. Great. Thank you, Amina. So about 4 years ago, almost exactly to the date, I came on board with Remote Focus. Remote Focus has been around for about 4.5 years, almost 5 years. It was the child of Rafael Nadal. Again, we bring up his name because I think him and I worked tremendously together very well in HHA Exchange. And he had an idea right before COVID, and like so many different other people's lives, it dramatically changed our trajectory of Remote Focus. So Remote Focus, in its exception, was an engagement platform, strictly looking to engage patients, to engage caregivers. The ultimate goal to reduce bad outcomes, increase good clinical outcomes, but more importantly, just engagement within the total care of the patient. Now, when COVID came around, what occurred is that we realized that there was a lot more than just a lack of engagement, but there was a real issue with clinical gaps of care. And I was quite surprised, even now I'm quite surprised, how many individuals, older individuals, frail individuals, multiple chronic conditions, didn't have a primary care doctor, didn't have a sufficient care circle, meaning proxies or loved ones, to help and assist them on their journey in this very treacherous landscape we call healthcare. Remote Focus became something more. Remote Focus, in its essence, is two parts. One being chronic care management with a total proprietary solution called Emicare, and behind the scenes, an actual human approach with actual physicians, nurse practitioners, PAs, MDs, governed by cardiologists. And so when you combine those two elements, you have a very powerful tool. But like anything else, if you don't have anyone utilizing the tool, what happens? It sits and collects dust, right? And becomes it's just a tool. It needs a human to move forward, at least for now, right? Till AI takes over. But in essence, with utilization of two parts, both the software as well as the human component, we're able to truly partner with home care agencies, which is really our sort of mission. As we've grown, we've also working with hospital divisions. We're working with community centers, nonprofits, social workers, and a slew of many SCEs, service coordination entities, and a slew of other what we call relationship partners or warm referral partners. And in general, what we do collectively and is in a partnership is truly assist these individuals to have that extra clinical eyes and ears and have that care circle and have this all being documented and put into a workflow that truly benefits everyone involved. So I know it might be a little long-winded, but in essence, what Remote Focus is a company that works with the whole landscape, whole ecosystem of home care and healthcare to ensure that patients have extra clinical eyes and ears to support maybe their primary care doctor, to support their families in quarterbacking their continuum and coordination of care.
So you mentioned various clinicians. So whatever Remote Focus is capturing through the software, some physician is reviewing that. Am I following correctly?
You hit it right on the nail, Mina. So I'll give you a quick workflow. So
Yeah.
essentially, a patient, I don't know, went on a hiking trip, fell down the mountain, survived, ends up in a hospital somewhere in Beacon. They get discharged in 3 days. All right, after they realize they didn't have a broken hip, but they're going to need assistance, and they also have hypertension, diabetes as well, and over 65. So in essence, what happens is either a child or maybe the hospital or even the physicians, because we do work with physicians, will say, hey, you know what? We're going to send you over to Remote Focus because we want to watch your blood pressure. We want to watch and ensure that you're healing properly at home. I'm also going to send over maybe a skilled nursing service, take care of some other things like that terrible wound that you have right now. Okay. So we'll get that referral through our portal. We have a patient portal or a portal itself that allows anyone to send over referrals for the patient. We then have a great enrollment team that will vet the patient, check for eligibility, make sure we can service the patient, and more importantly, talk to the patient and get an understanding of what's going on. At that point, we'll say, okay, patient, we're going to schedule you to have a telemedicine visit. You don't have to leave your couch. You don't have to leave home. You don't have to worry about getting transportation. We're going to come right to your living room through a phone, simple iPhone, Android, or tablet. And we have a very HIPAA compliant technology that will allow the patient just to click on this link right from their text box and have a face-to-face with a physician. At that point, the physician at their location is typing up their progress note, looking at the RIO, the Regional Health Information, looking at a complete short scripts background, a medication profile, the whole A to Z that you would receive as if you were in a brick and mortar.
I'm sorry, Desmond, whose physician is it? Is it the referring physician who is using your software to facilitate the telehealth?
No, it's ours. It's our staff, our actual physician.
So not the CHA's, if the referral is coming from a CHA, it is not the clinician from the CHA.
No,
This is an additional clinician who is now evaluating the patient beyond the one that referred the patient for
you
home.
hit it right on the nail. Yes, correct.
Okay.
Can I ask you about
Sure,
that? One more question about that.
sure.
The patients, do they sign up and become a patient of your physician in their census? Are they being managed and cared for by that physician?
Great question. It's very interesting in the world of healthcare, especially doctors, right? Doctors tend to have a very Hey, that's my patient mentality, right? And maybe for good reason. They do build relationships over the years with them. For us, we're supplemental physician services. We feel very strongly about that. We do not ever want to interfere with a primary care doctor's patients, nor are they our patients exclusively. We work under the umbrella from CMS under what's called chronic care management, under what's called APCM management, which is like a whole new acronym, but it's similar to CCM, which is chronic care management. So in theory, the patient is a primary care's, let's say a regular doctor's patient. However, think of us sort of as chronic care management specialists. So a regular doctor is not going to do what a cardiologist does or a urologist does. So we're a chronic care management specialty group. Some may call us an intervention group. Some may call us a patient safety group. So yes, we are on the hook, and to ensure that any services that we do provide are clinically sound and are supported by governance of not only the CMS, but also, the ACA, AMAs, and all the other colleges, right? Medical colleges, as far as thought processes. But in general, that patient or patients will typically give us a verbal approval that's documented and recorded, allowing us to continue their services. So I hope would that answer your question there? I don't want to be long-winded.
So, I mean, is that one of the pushbacks that you get? Well, I think the physicians may exercise some of that territorial mentality,
Mhm.
not strictly because of relationships, but because of their legal obligations,
Sure.
right? If that relationship is there with the patient, then they need to be careful about what other providers are in that ecosystem with the
Mhm.
patient, because if something goes wrong, they are on the hook. It's very
Sure.
similar to attorney-client relationships, right? So are you having issues coordinating all of that? It effectively means that there's two physicians on the patient side.
Yeah, so it's a great question because we have two, I would say, workflows, clinical workflows in that regard. The whole concept of chronic care management or telemedicine, even in general, even though it's been around for probably 15 years, it's still relatively new in the conscience of traditional healthcare. In essence, a primary care doctor is, on the hook or is responsible for the patient based upon the sort of the contracts they have with the insurance companies, in essence, right? The insurance companies will say, okay, Dr. Smith, you have 10,000 patients or whatever amount of patients that fall under your governance and your clinical guidance. And you're responsible to ensure that they don't go to the hospital, that they are getting proper care, and that you're treating them to the best of your ability. So yeah, it's even more than that relationship, right? It becomes, a liability that they want to ensure that they do the best job, meaning the doctors. For us, the doctors that we do connect with or, call us or ask us questions or have concerns, it's either two things. Are you taking away from my billing? Right? Unfortunately, they want to make sure, hey, and we'll say no. And second of all, are you trying to poach my patient? Not at all. But again, what we tell the doctors is we fall under chronic care management. You could do this yourself as well, Dr. Smith. And we do even allow that option too, where we'll even engage doctors who are willing to maybe want to work in the chronic care management space and help them through our software side. Right. And the other is that say, great, I love what you're doing, but I need to have visibility in what you're doing with my patient. So in that point, we allow full access. It's totally free to our patient portal, and we'll even do any types of interfaces to their what they call EMR system. In essence, again, I go back to the fact that we're considered more under a specialty or specialist umbrella. So it's like saying Dr. Smith, primary care doctor, wouldn't say to the cardiologist, hey, are you going to take my patient? Right? Because obviously they're not. They're going to take care of the heart, right? And the doctor's going to do general medicine. So most doctors will be fine with it. Other doctors don't know, don't even engage with the patient at all. And in other instances, we actually become and can be the primary care doctor.
I don't understand why a primary care would object to something like this because they can bill for these services and partner with you. So I mean, it's a
Hmm.
brilliant business model, and there are these services for both Medicare and Medicaid
Hmm.
you can partner with, and to be able to do it with a home care agency. I don't think you are a health home model,
No,
correct? Right.
no.
So, but to be able to do this chronic care management, there are so many wraparound services, and you figured out a way to do it successfully. And unfortunately, within healthcare space, it's very territorial. People are very protective. The state is trying to get collaboration to happen.
Right.
But people take ownership of the patient's lives instead of working towards the betterment of the care being delivered. So, I'm glad you've figured out a way to navigate that. And we work with you, and you work with our patients, of course. And we can speak more about that and how that relationship looks like for those who are listening and who aren't working with you yet.
This space is so unique that a lot of, let's say, even the home care space, or even now, we work with several service coordination entities as well, that it's a new concept that sometimes they just don't get it and can't wrap themselves around it. Because a home care agency at its true basic level is providing a staffing opportunity, right? But is kind of meshed in with making sure that the patient is medically sound, right? Is safe. And then on top of that, you're on the hook for compliance with caregivers to ensure that they have their medicals, that they have their certifications. The patient is, if you go into the whole value-based piece, is, you're hitting and helping with those XYZ metrics that are being enforced by the MLTCs, who in turn are being kind of pressured by the state, right? So it's sort of a trickling effect. And then that's where we really had a sort of that, wow, wait a minute. Home care agencies are on the hook for value based, both financially as well as for the basic patient safety. But what tools do they have? They have a home health aide. They're not doctors, they're not nurses. They have nurses, but good luck keeping a nurse for X amount of time because there's a shortage of nurses. So what do you do now? You need tools. And that's where I think remote focus and companies like remote focus, I think really help fit that gap where we can say, you know what, home care agency, you're either financially or regulatorily on the hook for these value-based metrics, and they're going to get more stringent over time. If you work with us as your partner, no strings attached, no contract, a simple BAA, right? A simple HIPAA agreement to ensure that we can talk about the patient. And then a verbal consent by the patient allows you to actually be a component and a champion for this patient's safety, as well as have a way to really foster and hit your value base on a monetary level. You also provide the efficiencies with the issues with staff, right? As you know, and I hate to always bring up money or in a clinical forum, but the reality is a lot of agencies across the board are looking for ways to be a lot more efficient based upon a certain bill rate that keeps shrinking every year or every quarter, right? So with companies like Remote Focus, we also provide the ability to have your coordinators, your staff rely on us for things that are not involving scheduling, like DME requests, or hey, I need transportation, or I really don't have much food in the house, or and a host of other things. I need imaging, and we get so many different requests, and a lot of times it falls to the coordinator or maybe the DPS. We take on that brunt at no cost to the agency. So we're basically a free tool. And not to say that we do benefit, and always very transparent. We do bill for CMS to CMS to Medicare Part B. But at the end of the day, we're providing such a value to the agencies without charging them. And on top of that, we're providing feedback to the agencies in relation to what the patient is saying. We have over 60 care managers that are calling constantly in different languages, talking to the patient, the loved ones, and listening to good feedback and maybe sometimes not so good feedback. But I always tell agencies, if you don't get any bad feedback, you're not doing your job. You're not growing, right? You're always going to have that one patient that's grumbling, or that somebody who says, I'm going to sue you for this and that, right? Well, the reality is we get to talk to those patients before that simmering pot starts exploding. And we can say, hey, Sasha, hey, Mr. Smith from XYZ Acme Home Care, this one patient, you may want to just give them a call and give them some love. Or, and they're all going to say, we want extra hours and this and that. I'll stop there. I don't want to take up the whole show here.
Well, you said something I want to just hone in on a little bit. You may have heard me say that coordinators really carry a lot of responsibilities, so much
Yes.
more than what they're being compensated for, and you taking over some of those more clinical conversations that are typically given to the coordinators, which,
Hmm.
personal opinion, they shouldn't be having. They're not
Right.
qualified to have those. What has been the feedback from the users of your platform about how that works? Are you finding, I'm sure you're doing some return on investment or analysis of where you're doing a good job and
Hmm.
remote focus, I mean, and where you have room for improvement. But
Sure.
what's the feedback been there as far as taking off those more clinical type of conversations off of the coordinators' desks?
Oh, sure. Great, great piece. And, we have folks that are out there, not just myself, who are walking into these home care agencies, talking to these coordinators, looking for those pain points. And that's exactly it. The advice or the direction that a administrator of a home care agency tells their coordinators is, if the patient says they're not feeling well, tell them to go to urgent care or call 911, all right, or run to the hospital. We've changed that, right? Now we have a triage effect where the patient can call our 1-800 number. They can actually send, if they're using the app. I'm not going to say they use our app extensively. They are not as technology savvy as, being a little older folks. Not doing any type of ageism here. But the reality is that we provide another vehicle for these coordinators to not have that type of conversation, to not put themselves at risk, but yet not to ignore the obvious concern of that patient. So the coordinator's feedback is, Desmond or the representative from Remote Focus is, hey, you guys are God sent. You take a lot of things off my plate, and I'm able to now schedule a lot more cases. And then the administrator is saying, hey, this is really kind of cool, because now when my nurses go out twice a year, you have all this data that's been happening the last 6 months. Now they know what's going on. They may not know there was a wound situation, or, or diabetic foot, or whatever it might have been. And
Yeah.
so we're providing that extra documentation, I think reduction in risk. And because, hey, we have malpractice liabilities, so we'll take it on. Anything we do, it's on our shoulders, not the agency. And they're like, okay, great. And that's one of the major things sometimes I do have to overcome in explaining what we do, is that they're like, well, if we don't know, then we don't know, right? And we don't have to worry about it. And I says, look, it's better for you to know, because you're providing total care in a sense, but we're taking care of that clinical component.
Okay, so is it safe to assume that anybody who is Medicare Part B eligible would then be eligible to have your services? And you work with agencies on identifying which of those patients meet the criteria and get them enrolled.
Correct. Yes. Yes.
Okay.
Yep.
Okay,
Yeah.
great.
We do an extensive piece where and we also, we have a portal,
Hmm.
and the portal allows visibility of what we're doing. It provides the ability for them to export data, as well as provide what we call warm referrals, and upload any documentation.
Hmm.
And so what that does is it gives the ability to see exactly what we're doing. And, at the end of the day, we don't work for the home care agency. We're partners. But they're able to then use that data. Some of them are using it to kind of talk to the MLTCs about, hey, you know what? Well, look what I'm doing. I'm a little bit different than the agency out the block that doesn't have a company like Remote Focus.
Right.
And now, after 4 years, the MLTCs are looking at us a lot more.
Mhm.
And that's not us. I always like to say I'm not the only one on the block. At the end of the day, the MLTCs have approached myself, Raphael, our CEO, looking at how they can incorporate something similar, but maybe we do all the work, right? So it's kind of exciting, because the MLTCs are getting pressured even more now. Hey, how do you save dollars, provide great care, and also, I always want to say with this whole CDPAP thing, right? That's still lingering, right? And it's crazy world of home care, but even now more than ever, who's the next one in the bullseye, right? It's the MLTCs, and that's what I hear in the streets. I don't know. Maybe you guys.
Can I ask you another technology?
Yeah, sure.
Your EMR background, your the founder's EMR background, HHA Exchange. What's the integration like there? And is there a specific module you would need an HHA Exchange to be
Ah,
able to take advantage of that? And is there integration with other EMR
sure.
platforms?
The beauty of it, since the founder is basically a workflow, very versed in software platforms, it's an open AI. It's pretty much, I would say, 98% out of the box, right? It's patient demographics, clinical medical information. We do have an HHA Exchange Google extension, right? So we did that intentionally because it reduced any barrier of cost, right? When you try to do interfaces, software companies will tend to charge their customers. We didn't want that. So most people are familiar, can use a Google or Google extension or an extension in general, and they'll actually get a little icon on the screen. You click that icon and it scrapes all the patient demographics from an HHA exchange or theoretically from any of the other what I call home care practice management solutions, the Elias, the visiting aides, et cetera. And so the beauty of it is that we reduce the barrier of cost, but we provide the beauty of efficiency and integration.
So just a bit of a, I guess, a legal plug here. Whatever provider is looking at a platform like this and considering signing on, you do need to have an attorney review the services agreement because if you are receiving this data on an ongoing basis about the patient's condition and you are not responding appropriately or timely, and the patient is subsequently injured or their status, their condition is worsened, both parties are on the hook, right? There is this joint liability situation because as soon as you have knowledge, you have a responsibility to act on that knowledge. Those provisions in the services agreement have to be carefully looked at. And I'm still not sure actually right now because there is a point where you said we have our own relationship with the patient independent of the agency. So how does that sharing of information really flow and the duties and the legal obligations? That needs to be looked at.
Sure. Yeah. And a very good point. And I think there's a couple of agencies, I've done the great due diligence on the legal aspects to incorporate clauses, and we do it all the time, specifically outlining, hey, in the event of XYZ adverse events or death or wrongdoing in a clinical aspect, that this will fall, under I guess, basically on the umbrella of remote focus, right? Because at the end of the day, we are a physician group. That's something that, yeah, I definitely a good practice for everyone to look at, what we send over as far as our BEA, HIPAA, and maybe have some language around that. I agree. Right. And at the end of the day, we want to keep everybody safe and sound, not just the patients.
Can you speak a bit about the possible cost savings that an agency could benefit from for your services? And this may or may not be the case, but I just wanted to know, like medical orders, and you spoke about working with service coordinators with the NHTD program, and where can you step in and assist or do some of the those visits that agencies need to be able to provide service?
Sure. No, great question. Over time we've evolved. We were working mostly only with home care agencies, and then, as the nature of healthcare, home care evolves, this whole NHTD program just exploded, right? To the point where now they're sort of capping, right? There's a capping going on sometime, I think next month, if I'm not mistaken. Early on, we saw that there was a relationship between service coordination and home care agencies. Now, the only stipulation was that home care agencies couldn't solicit and say, hey, go to this service coordination entity, right? Just can't do that. We saw this, Remote Focus saw this as, hey, we can be the bridge between these two providers in a sense, right? Yes, we are very similar to a service coordination entity, but we're not. We're a physician group. So we do very like-minded tasks, in other words, of providing or quarterbacking the care of a patient. For example, an SC service coordination entity will, work with the home health aide, work agency, work with transportation, work with making sure the patient is seen by a psychiatrist if there's any type of anxiety, whatever the case may be, the total care. And then they bill, once a month, and they have all this documentation. What we saw is like, you know what? We can help them, especially in efficiencies, because technically I think they're only allowed to see, or per SC, 25 participants. You have one person working with 25 individuals. We come in, we provide a lot of efficiencies. That equals to cost, right? They spend less hours on this, they can grow their business. And a home care agency, again, you don't have to hire more coordinators. They're not doing any of that clinical type stuff or coordinating as much anymore because we took over that space. So they save quite a few dollars there. Another major thing, yes, medical necessity forms, right? Now we don't do the UASs, right? So we can't do that. That has to be done by someone on staff. But the medical necessity forms, along with several others that we work with, we have partnerships with some other folks that do that, can do that as well. So, that helps start a care, right? So you can't get paid unless you have started care. Then the patient goes to the hospital, they get discharged, it becomes another cycle, right? So we help with those efficiencies every day. That return on investment is dramatic. On top of that, we've seen it already, the what we call the health scores with value-based, right? There's dollars there. There really are. Some folks may not see it, some believe, but there are value-based dollars. And we've seen scorecards dramatically improve when they started utilizing our services, especially the larger, 2, 3, 4, 5,000 census agencies. They've seen a dramatic increase in revenue they earn through the value base. And then finally, on top of that, savings, I would say really savings is keeping your patient. If you have extra eyes and ears, you can reduce patient fallout, meaning they can, technically they can leave in the middle of the night and end up in another home care agency, right? And not tell you. So we've helped increase, or I say maintain patient census by alerting the individuals, hey, this patient's not happy for XYZ. Were you aware of this? No, we weren't. All right, get on top of it. Right. So I think across those all four spectrums, we help reduce costs, increase efficiency, and I think quality of care. Also, as far as branding, right? If you can say to a loved one's family, hey, you know what? You live in Chicago, you're paying me a private pay rate, for example. We have a service that's going to allow you to see your dad, your mom's blood pressure, see what their pulse is, see that they're getting transportation, seeing that they're getting all these services, and you're in Chicago and Florida, they're here in Brooklyn, and you can feel safe that we're going to take care of your mom and dad. And that to itself is priceless.
That's a very good point. So you're involved in the private pay space as well, not just Medicare,
Yes.
Medicaid.
Correct. Yeah. So it's been a good, some private pay or even agencies that let's say are MLTC original, like, whatever, pretty much most of their dollars and do have some pay cases are putting sort of like a bronze tier, a gold tier, a silver tier, and charging X amount when they utilize remote focus.
Desmond, thanks so much for joining us today. I personally learned so much about what your company does and what this service is generally, because it is a federal chronic care management program service that you ultimately provide through the software. So thank you for sharing all of
Oh,
that.
thank you. Thank you so much, guys.
Thank you for joining us, Desmond. Thank you, Emina. This has been the Home Care Forum podcast with your hosts, Sasha, Guillaume, and Emina Poricanin. Have a good one.